So good afternoon, everybody. So we are entering the last session of this symposium, and before we go into that, and I introduce John Seeger to you, who's managing the next session, I want to announce the poster award winner, and it was really 11 really interesting and quite good posters that we saw there. And again, do you see the heterogeneity of different methods that were utilized there? So very stimulating, really. So really appreciative of each and every one of those posters. And at the end, we had to decide on only one winner, and it turned out that Romain Neugebauer is actually the winner of the poster award this year. So congratulations. And you don't have a certificate, but you have a ribbon there, so you can put that on your sweater now. Walk to the airport like that, so that's great. So thank you very much for your submission, for all the submissions for the posters. That I think was quite successful. And then, so let's move into the last session, and it's chaired by Dr. John Seeger, who's a pharmacist and pharmacoepidemiologist, who has joined our division actually 1.5 years ago, was in industry for 10 years, has tremendous experience and in large database analyses. So thank you very much.
All right, so starting off the next session here, we have Dr. Beth Devine, and she's from the University of Washington. And there's a nice tie-in to the introduction Albert Wu gave this morning on sort of patient-centered orientation to the research, sort of designing research that addresses questions that apply to patients or that patients are interested in knowing about. And so we're looking forward to what really is meant to be a case study in designing comparative effectiveness research.
Well, thank you, John, and good afternoon to all of you. This morning's sessions were really great, so we hope to continue in that vein. And I mentioned my thanks to Al Wu this morning for teeing up my presentation. I could take this in several directions this afternoon, but John specifically asked me to speak about stakeholder engagement with patients and then also secondarily with clinicians in our project. So I'm here to share with you a little bit about the Scope Certain project. We have a pilot study in the area of intermittent claudication. Our PI on this project is Dave Flum. He's a surgeon at the University of Washington. And we received support from a very unique method from AHRQ, which is we're part of the prospect portfolio, if you will. It's using electronic data to conduct CER studies. But within that broader term of that portfolio, there are 2 funded studies nationally that are to use QI registry data and to morph those into data used for comparative effectiveness research. And we hold one of those grants from AHRQ. So I'll explain to you what Scope Certain is as we go along here. So SCOPE is the Surgical Care and Outcomes Assessment Program. It began as a grassroots initiative to own surgical quality and cost in the state of Washington. It's led by clinicians, so that's your first stakeholder group there. And it's housed at the Washington State Foundation for Healthcare Quality, which is a nonprofit organization. It was initially funded by the Washington State Life Sciences Discovery Fund grant in 2007, and so has had 5 years of building and building with collection of QI data statewide. The concepts are simple. We use benchmarking quality data to improve the healthcare quality and of surgical outcomes for patients and in the state of Washington. We use a checklist initiative. If you've heard about the checklist in the operating room, we've adopted that throughout the state of Washington. And so SCOPE is actually now self-sustaining, improving health care. We give a lot of feedback to clinicians at different hospitals, and we've actually reduced health care costs along the way, which is always a nice side benefit. And we continue to develop the program, as I will show you in a few moments. So this is the scope of SCOPE. We currently collect data for QI purposes in surgery across approximately 55 of the 60 hospitals in Washington state. And over the past several years, we've actually bent the cost curve, for those of you who like health economics, from years 2006 to 2009, in treating approximately 36,000 patients in our database. We've saved approximately $67.3 million among the different surgeries that we follow with benchmarking and improving practices. So now our goal with our AHRQ grant is to take these QI data and this framework that's been built and to begin to use it to conduct comparative effectiveness research studies. So the AHRQ grant, the intent of that is to create enhanced registries, if you will, using multiple data sources linking to multiple electronic health records, which we are doing. It's not the focus of my talk today, but I'm happy to talk with folks separately about that. To evaluate data from across more than 2 delivery sites, to overcome the common barriers of registry data, easier said than done, and to create CER and link outcomes to advance both QI and CER along the way. To provide a platform for dissemination and translation, so again, our stakeholders are coming into play, and then to use our stakeholders and real-world clinical practice to address these questions of CER, what really is most important to patients, but then not only to patients, but to clinicians, to payers, to industry, to employers, and the public. So we're also building an automated data flow and then leveraging our success for dissemination and translation. Here you see our structure in terms of our overarching advisory board. Collects individuals from a variety of backgrounds to inform our work, to guide our work. We have an executive committee that leads our work. We have an administrative core. We're very, very fortunate to have a large administrative core who really does deliver, it collects the data, does much of the outreach, and is absolutely second to none. We have core leads, and I think this might be of interest to several of you in the audience. I, along with Dave Flum, lead the Comparative Effectiveness Research Methods core. We also have a biostatistician, so it's also the data core, if you will. We have an informatics core. There's lots of work going on in that area. We have a patient core. We have patient-reported outcomes. We have a survey center. We have a patient advisory group. We have a clinical core, particularly for this particular study in vascular surgery. We have 3 vascular surgeons who work with us, who guide our work, and then we have a data core with analysts as well. And then we have site coordinators and project coordinators, as I said, who disseminate and really do the on-the-ground work for us. But you can see the number of hospitals that are involved in this particular study, the intermittent claudication study, along the bottom there, and there are a fair number of those. So this is the structure of the scope. You can see along the bottom that the clinicians and the hospitals are really the infrastructure. We build on that. We study for QI, and now in blue for research purposes as well. General surgeries, appendectomies, colonectomies. We're moving into the area of spine surgery, cancer surgery, bariatric surgery, and vascular surgery for this particular study. And you can also see, find my pointer, that we have in the middle there CERTAIN, which stands for the Comparative Effectiveness Research Translation Network. So you see the informatics component. But what we're doing now is we're enlarging our infrastructure. So we have informatics tools. We have outpatient care. Heretofore, we've been focused on surgery. We're now pulling in primary care physician practices so that we can ask additional CER questions, and the patient-reported outcomes, and then medically managed cohorts of particular note for the intermittent claudication study. So the study itself that I'm focusing on today, a little bit of epi for you. The peripheral artery disease affects approximately 7.3 million persons over the age of 65 in the U.S. Claudication is the most common presentation of lower extremity PAD and affects approximately 5% of U.S. adults. It manifests as pain, which is an imbalance between oxygen consumption and delivery. And then disease progression actually limits walking. That's key because our primary outcome is a walking impairment questionnaire. Considerable expenditure of healthcare dollars, and it's expensive, but the best intervention really has yet to be determined, and that's what we're about. Our study design is that we're conducting a multi-site, longitudinal prospective observational cohort study of interventions. We call it a pragmatic trial, in that it's designed to determine the effects of an intervention under usual conditions. Where we help users to choose among their options for care is one of our goals. We have 3 cohorts, and this is one of the unique features of our study. We have an open surgical cohort, we have an endovascular stenting cohort, and then we have a usual care or conservative or medical management cohort. So 3 very unique strategies for treatment of this disease, and so we'll be studying all 3 of those, and we're measuring outcomes at 30 days, 6, and 12 months for this population. Our hypotheses are 2. That surgical interventions, open surgery that is, are associated with greater improvements in function, improvements in claudication symptoms, and in health-related quality of life than either endovascular procedures or medical management. And then secondarily, that surgical and endovascular, because those are closer together, are associated with greater improvements, as listed above, than the medically managed group. We spent quite a bit of time developing a conceptual model. It's in the slides. I won't go over it in detail, but just wanted to focus on the fact that our clinicians were very much involved in the development of this conceptual model for us, and it includes many of the covariates that we'll now be including in our models and our propensity scores that we've been talking about this morning. We also have our outcome and our PRO estimates along the bottom. We have the walking impairment questionnaire, which I said we were powered on. I'll talk about that a little bit more. We're collecting or administering the EuroQual 5D and several other instruments as well. Our inclusion and exclusion criteria are very broad. We spent quite a bit of time talking about this. We hope to enroll approximately 700 subjects. Our inclusion criteria are limited to those who are experiencing infrainguinal claudication, so superficial femoral, common femoral, or popliteal artery claudication. Mild, moderate, or severe. So there you see the heterogeneity inherent in the population that we're studying. The surgical arm, we're including those who have synthetic or endogenous vein or composite graft surgeries. For endovascular, either angioplasty or stent. And then the conservative management requires ongoing care by a physician that involves a walking program, a formal walking program, smoking cessation counseling, and perhaps medication management. Exclusion criteria include documented ischemia, rest pain or ulceration, and interestingly, we're having to exclude many, many patients that would otherwise qualify, so we're having recruitment challenges, which I think might be of interest to several folks as well. Claudication of aortic or iliac origin, we're not including those. Claudication not of atherosclerotic origin, and those, of course, the usual limitations, so those without access to telephone and whatnot. We're collecting data from medical records. We're also administering PROs, and we hope to get to administrative claims data. This slide focuses on the medical record data collection. You can see on the left-hand side that we have the left-hand column is the study measures, and the middle column is the data source, and then the right-hand column is the time intervals at which we will be collecting these data. So, of course, we have the inclusion-exclusion criteria. We're collecting data on demographic information, medical history, clinical baseline measures, and whatnot. And then for the surgical and endovascular arms where we have inpatient utilization, we can also capture those data as well. And then you can see the different data sources from which we're collecting the data. This slide is important in that it lists for you the patient-reported outcomes that we are using. And these were developed and chosen in concert with patient involvement. So, of course, we have a baseline health history. It was developed in particular for this study, and it is a telephone interview or administered by paper and pencil or web-based. We have several modes of administration. As I said, our primary outcome is actually the walking impairment questionnaire, a measure of functional status. I think one of the only trials that I'm aware of that actually uses a patient-reported outcome as the primary outcome measure. A disease-specific quality of life measure called the VascuQual, which is in the literature. Health-related quality of life, the generic instrument, the EQ5D, the 5 level now we'll be using so that we can conduct a cost utility analysis down the road. Edinburgh Claudication Scale to capture leg pain. And then importantly, we developed our own patient symptom questionnaire by interviewing patients and having focus groups with them because we didn't feel that there was an instrument in the literature that helped us to capture really what we thought the patients were experiencing. So that was actually a sub-study that we've already conducted. Similarly, we have what we call a mode of administration study, which is also a sub-study where we're enrolling 72 patients and administering the same battery of instruments to them in different modes. Web-based, paper and pencil, IVR, or live telephone over time to see how much those estimates change by mode of administration, and then we can adjust our analyses accordingly. Our administrative and health resource utilization will capture hospital readmission data through a very nice data set that the state of Washington has called the Comprehensive Health Abstract Reporting System, or CHARS. Mortality data, of course, will link to vital status records from the state of Washington, and then treatment encounters and outpatient visits with claims data that we are currently negotiating with our different payers, and then we'll use those to conduct our cost utility study. Our analytic outcomes, as I said, the primary instrument walking impairment questionnaire 12 months after the procedure or intervention. Secondary PRO outcomes or change scores on the instruments, the battery of instruments that you saw on the PRO page. And secondary clinical outcomes are death or a composite endpoint of any of the following for the surgical arm, reintervention, amputation for ischemic conditions, MI or stroke, and then failure to be discharged, so some available through the administrative claims data, and then health resource use. Traditional analytic plan, although we're certainly following Bayesian adaptive designs at this point, we intend to apply those to our spine study that we're now launching. But longitudinal data analysis methods, assessing temporal changes in time, baseline to different outcome time points, using GEE to account for repeated measures over time with robust inference, selection bias and confounding through propensity scores or instrumental variables. Missing data is something we're paying large attention to because we do have the PRO data that we're collecting. And then we have crossovers as well. It was very challenging to actually determine our inclusion-exclusion criteria because so many of the patients who proceed to surgery have already been medically managed for a number of months or a number of years, and then some of those go in the other direction as well. So we'll be having to take those issues into account as well with our biostatistician. This slide illustrates for you the power estimate based on the walking impairment questionnaire. So at the very top, you see the three groups on the left-hand upper left, the medically managed cohort or the usual care cohort, the endovascular and the surgery cohort. The next column is the percent change over time, and this is deceptive. Actually, it looks like the medically managed cohort does a little bit better with 15%, but actually this is a decrement in walking over time. So you see that the medically managed cohort we anticipate will do more poorly than the surgical or the endovascular cohort. And we also note that the endovascular and surgical cohorts are quite close together in terms of the 5% and the 7% change over time. Estimated sample size in the next column, and then if we are unable to obtain that wished-for sample size, then a reduction to 90% and 80%. So these were all of our calculations going into the study in terms of estimating our sample size. The walking impairment questionnaire itself is comprised of 3 domains: walking speed, walking distance, and stair climb, all of which affect intermittent claudication patients. And so we did several different scenarios here of powering our study and coming up with a sample size based on the difference between the groups, which groups we're comparing, and the amount of correlation before and after within each patient. And then with different sample sizes as well, what you see here are the sample size of 700 patients and then our power accordingly. So 700 is our goal. And now we're trying to get to our certain best results with patient-reported outcomes. As I mentioned, we have the pilot study to develop the new symptom measure, enrolling 10 patients. We have a pilot study to validate the survey modes, enrolling approximately 72 patients. We're dealing with issues of data management, security, database linking. Institutional review board approval, of course, was big for this particular study. All of the patients in this study are consented, so it's a very traditional IRB process, but some of our informatics initiatives really do cross the line between quality improvement and comparative effectiveness research, and that's opened up a whole host of issues that we're working through as we do that. Training project coordinators for a project like this is not an easy task. It takes a lot of time. Everybody needs to be trained consistently. That's quite important. And then recruitment and retention of sites and subjects has actually been a little bit more challenging than we had thought. We're getting different sites on board at different intervals, so sort of a rolling site involvement, if you will. Certain sites are contributing certain types of patients, particularly at the UW. We're finding that, of course, that many of our patients are excluded because their claudication is so severe that they're approaching the point of ischemia. So we're getting the medically managed patients at the University of Washington. And so as we bring more sites on board, we're hoping that the enrollment in terms of enrollment per arm will even itself out. But even so, we've adopted a strategy of trying to ramp up our recruitment, and that's what this slide illustrates for you, that we actually created last December, and we're in the process of rolling out right now. You can see the different actions that we're intending to embark upon in the left-hand column, and in the middle column, the next quarter tasks, so what we wanted to achieve, and then who was responsible, which of our cores that I showed you earlier on are responsible. So we have initiatives on the front of site recruitment. We have initiatives related to physician engagement. Our vascular physicians are holding meetings with their colleagues, to which some of us are invited so that we can speak about the program and encourage enrollment of their patients in our study. We're actually looking at our enrollment criteria again. Do we have the right inclusion-exclusion criteria? Because our enrollment right now is at 50 subjects out of the 700. And then can we begin to identify patients retrospectively by going back into the quality improvement database and sending letters to patients asking if they're interested? So we're trying to think outside of the box to get our recruitment numbers up. So that's a challenge. here are a couple of slides that I wanted to illustrate for you about the stakeholder engagement. Our patient-reported outcomes core and our PRO survey center are really putting much effort into involving these patients. As I mentioned, we have had patients involved in the 2 sub-studies that we've conducted and are currently conducting. We have a website here where we're encouraging patients to become involved. There's a place where they can provide their input to us. We're actually also creating a patient advisory board of Claudication patients so that we can receive their input and make sure that we're measuring outcomes over time that are the most meaningful to them. We've actually called this our Patient Voices Project, and we're actually also using this in the quality improvement space as well as the CER space. And in the QI space, what we've done is we've launched an innovative web-based system that manages patient contact post-discharge. So this is QI. This isn't necessarily the study because the study is taking place alongside. But again, we have the multimode survey administration that we're using, web, post, and then live operator interactive voice response, and we have 16 hospitals right now, and a response rate's about 60%. I will state that we have an algorithm for patient contact that is intense and extensive, but it really does work for us. And so we can see right here that some of the work that we're doing in the comparative effectiveness research space is already being translated back to the QI space, which is really nice. So the strengths and challenges, it's a great pragmatic trial. It's exactly where we want to be and what we want to be doing. We do have a heterogeneous population. We're pleased that we've actually been able to make it patient-centered and that we're currently bringing increased levels of sophistication to that particular part of it. We've also been quite successful in engaging our clinician stakeholders, that is our vascular surgeons for our study. And then our patient stakeholders with our survey center, patient voices, advisory panel, and then a dedicated website, as you've just seen. So we feel that we have made a good effort in involving patients in their care, and with intermittent claudication specifically, the vascular surgeons have found that their outcomes do not match the patient outcomes. So we feel that this is a really nice prototypical area to study because from a surgery perspective, they go in and fix whatever the problem is and everything should be fine, and the patients don't feel quite that same way. So that'll be interesting to compare those clinical with our patient-reported outcomes. And we do hope that we'll have high-quality evidence at the end that will aid real-world decision-making in this area of intermittent claudication, and that we'll be able to use the same model for spine surgeries and other types of interventions that we wish to study. And also our patients will feel better if they've been involved in the process throughout, and that we will be measuring outcomes that are meaningful to them. So a really nice group of collaborators, which I'm pleased to be involved in, and happy to take any questions. Thanks.
And I would like to note that we will have a general question-answer session at the end, but Dr. Devine will not be a part of that because she has to leave early for a flight. So this is a good time to ask any questions for her.
Hi, Beth. Darrell Gray from AHRQ. Just curious as to what instrumental variables you anticipate potentially being able to use in this context, given the study design.
Yeah, so that's a great question. Actually, we haven't had that discussion yet. Some of these discussions today in terms of the location and the geography are things that I'll be taking back to our group. Right now we're actually focusing on the propensity score methods, but particularly after coming to this meeting, I think I'll revisit. Every once in a while I bring it up, shouldn't we be using instrumental variables? And I kind of get, no, we don't need to do that. So we'll revisit it again.
So what propensity score is, do you have any idea what sorts of things, because obviously given the options for the different interventions, there's always the confounding by indication. So what propensity scoring?
Yeah, that's part of the problem of the whole study is that you've got people are funneled into different interventions based on the severity of their disease and whatnot. So traditional. We will have baseline measures for each of these patients, and so to the extent that patients can be their own controls, then we will use that and capitalize on that as well. But I think we probably have more work to do in that area. Yeah. Jeff?
Jeff White, Director of Drug Evaluation for WellPoint. No methodology question. Just want to thank you and congratulate you. It's a wonderful presentation and a nice case example of where you have a research concept that's relevant to healthcare decision-making, and you can connect the dots between the concept, the research, how it's going to impact healthcare. So I just want to thank you for that.
Oh, thanks very much, Jeff. Good. Okay, thank you all.
right. For our next speaker is Dr. Soko Setoguchi from Duke. But just briefly, before I let her take the podium, it was in doing comparative effectiveness of devices, you can sometimes encounter problems that you might not encounter in other research areas, and in particular, one is immortal person time, just because the definitions of exposure may include multiple occurrences of claims or procedures, and so we'll learn more about that with today's presentation. Thank you.
Good afternoon. So I'm going to be talking about methods to handle immortal person time bias, implications in clinical effectiveness of implantable cardioverter defibrillator. And this is a study that my colleagues listed here and I've been doing for the last several months in terms of understanding immortal person time bias in the context of assessing comparative effectiveness of medical devices. And the bias has been really extensively described in pharmacoepidemiology, especially in the example of COPD treatment by Sami Swiss et al. But there's little known about how this play into in terms of assessing effectiveness or comparative clinical effectiveness of devices. So a little bit about immortal person time bias, which probably most of you know very well. But immortal person time bias is a period of follow-up time during which, by design, the study outcome cannot occur. So if not properly handled, it can cause bias, which is usually called immortal person time bias. And what happens in observational studies of treatments of effectiveness or safety, immortal time bias can arise when comparing treatment options that might be applied at the different stages of the disease course. So in fact, this bias was described back in the 70s in the context of assessing the effectiveness of heart transplant. And there was a series of discussion in the literature, and then where Mantel and Bayer proposed to classify person time as patients accrue their time to various exposure status in the study of effectiveness of heart transplant. This was known as sort of a time-dependent exposure estimator now. And in the 80s, actually, Anderson described a similar bias in the context of assessing sort of a survival in responders versus non-responders to cancer chemotherapy, and where they described that Mantel-Bayer is one sort of appropriate method to handle this immortal per time. However, they propose another method called landmark method as another sort of alternative validated approach, which I'm going to describe later a little bit more. And in the pharmacoepidemiology, we know simply excluding time, immortal time from the analysis was considered to be inappropriate. Another issue, which is not really specific to the context of medical device or even pharmacoepidemiology, is that the time scale, choice of time origin and scale, which I call time scale, can affect the composition of risk set and therefore estimates of the hazard ratio from Cox proportional hazard models. So if you sort of do not choose the right time scale in the Cox proportional regression, the validity of the method handling immortal person time could be affected by this. So we wanted to sort of look at the method at the same time as this choice of time scale to see the impact of these methods on the in assessing comparative effectiveness of cardioverter defibrillators. So implantable cardioverter defibrillator, ICDs, is a sort of a implantable medical device to treat prevent sudden cardiac death in patients who might die from cardiac arrhythmias. And patients with heart failure has a especially high risk for these ventricular arrhythmia that could cause sudden cardiac death. And then randomized trials, of course, multiple trials were conducted to support the efficacy of ICDs in heart failure patients with a low ejection fraction. And then, for example, the largest trial, Scott-Haft, showed a 20% reduction in all-cause mortality. In MADIT-2, this is the second largest trial, so found a 30% reduction in the risk of death in this population. However, as you all know, that the trials sort of select out specific patients, which is not really representative of the general population. Also, the setting is really controlled there, so that real-world effectiveness of ICDs, especially among those patients who are older and have comorbidities, are unknown. And so that really leads to the needs of studies to assess the real-world effectiveness of ICDs in elderly heart failure patients. Aside from the usual sort of challenges that you can think of, which is confounding by indication and healthy user bias, there's another sort of issue there in terms of assessing ICD effectiveness about this, how to handle sort of immortal time bias. So we thought this ICD is a nice example because guidelines do not recommend use of device ICDs in new heart failure patients. And therefore, the ICDs are probably more likely to be used at later stages of disease progression, creating more immortal time for ICD recipients. Of course, as I said, this is not a specific to ICD situation, but appropriate time scale is unknown. In trials, people tend to use time on study as a sort of time scale, and which would tend to be adopted in observational settings, but the previous studies show that this might not be the best time scale in the observational data, and age or other time scale might be the better time scale. So we also wanted to see that in this context. And to understand the impact of method of handling immortal person time bias and choice of time scale, we conducted a sort of observational study using data from American Heart Association Get With Guideline registry, which was linked to Medicare data, 100% research identifier files from CMS between 2003 and 2009. And because we did not have unique identifiers in the registry to link to Medicare data, we linked the data using deterministic linkage method with multiple non-unique identifiers. In a separate study we conducted recently, that we found this method has very high specificity, sensitivity, and PPB compared to the method using unique identifiers. So the linkage is really quite good here. In terms of study patients, we identified a cohort of patients with heart failure who are at least over age 68 at the time of first recorded hospitalization in the registry, and they were eligible for Medicare during the 3 years prior to the index hospitalization, had low ejection fraction because this was the indication for ICD, and no contraindication for ICDs. And because we wanted to identify new users, we excluded patients who already had ICDs prior to the index hospitalization. And we also excluded people who had a prior history of ventricular arrhythmia because we wanted to sort of look at the effectiveness in primary prevention patients. And we also excluded a patient coming from hospital that did not have an option to provide ICD. In terms of exposure, new ICD implantation for primary prevention was the exposure of interest. So this is a schematic example of how ICD or patient with heart failure might come into the study. This is a birth, and then they might have first heart failure hospitalization, which may or may not be the same as index hospitalization, which was recorded in the registry, which was the index hospitalization, and this is the start of follow-up because that's when the data would be available to us. And then a patient may receive ICD after the index hospitalization, or they might receive ICD during index hospitalization. So if we use mental bio method, remember this red line in index hospitalization and green is ICD date. For those who had ICD during the same hospitalization and index hospitalization, their person time from the start would be classified as treated. However, if patient receive ICD after index hospitalization, the time from index hospitalization to ICD would be classified as untreated and categorized as untreated person time. And after ICD day, the time would be categorized as treated. Whereas if you use exclusion method, the time, it's the same for the first example here, but the second example, the time between index hospitalization and ICD date would be actually excluded from the analysis, which we consider to be inappropriate. In the landmark method, researchers have to specify a certain time frame after the sort of index hospitalization or after the start of follow-up, let's say 30 days after index hospitalization or 90 days, 120 days. Then you will classify the exposure status at the time of let's say 30 days, which is the landmark time. And then after that, the time after this landmark time will be categorized as treated if patient had ICD before this landmark time. Whereas if you had ICD after landmark time, you won't be categorized as treated in this case. And another sort of point here in landmark method is patients who did not make it to the landmark time will be excluded from the analysis. And in terms of time scale, we looked at 3 time scale. One is a study time from the start of follow-up, which could be index hospitalization, or landmark time for landmark method. And then another time scale we wanted to look at is, of course, disease course. I think the ideal disease course time scale would be the time duration of heart failure, which was not really available to us. So we tried to identify the first heart failure hospitalization by looking back 3 years of the data in Medicare, which we know that it's still incomplete, but we wanted to use this as a sort of a surrogate measure for the disease course time scale. And then, of course, the third one is the age, which is time from the birth. Analysis, we estimate the effectiveness of ICDs on 3-year all-cause mortality using Cox proportional hazard models. We looked at different ways of adjusting potential confounders, inverse probability weighting, match propensity score, and PS in the regression model. Propensity score was calculated using high-dimensional propensity score method. One note is that we were not able to use sort of rich clinical information from the registry in this case because we wanted to look at the time-varying factors in the data set, whereas the data coming from clinical data is only available at the baseline. And we wanted to make the adjustment comparable to each other for the method, so we just used the Medicare data in terms of confounding adjustment. So here's a study population. We identified about 4,500 no ICD patients, 650 ICD patients. ICD patients tend to be younger, likely to be more male and white Caucasian, and had more ischemic etiology of heart failure. The ejection fraction tend to be lower in ICD patient, even though we restricted the patient who to have less than 35 of ejection fraction. And they tend to have a little bit lower systolic blood pressure as well as serum creatinine. And on the other hand, that a patient with no ICD had more heart failure hospitalization, other comorbidities such as anemia, chronic lung disease, renal insufficiency, diabetes, and other cardiovascular diseases. This is just to show you the number of events so that you can see what the sort of power we have in the study, even though the study population was quite small, that this patient had a very high risk of dying, so we had enough power to estimate a moderate to moderate side effect. Note that the number of sort of denominator patients vary by the method because you sort of sometimes exclude patients from the study depending on which method you use. So here is the sort of a hazard ratio from the unadjusted, inverse weighted, PS matching, and PS as a covariate. And then rows are the different method landmark, Mantel Bayer, and exclusion. And to simplify, we just used the time, study time as a time scale here, although I had more results looking at different time scale. And in terms of one thing that you immediately ask would be to what's the gold standard here? So we know the effect estimate from the trials are around 0.7 to 0.77. What I'm looking for here is really not exactly that number because we know that from the literature, in the elderly population with more multiple comorbidities, the contribution of sudden cardiac death is really low. If you remember the presentation from this morning from, I think it was Jason, showing the risk of sudden cardiac death in the population that you saw different age groups, and then that incidence rate was actually increasing as the patient ages. However, the number of deaths increases, so that the fraction of sudden death in the elderly patients actually is much smaller than the younger population. So if you, again, the outcome here is all-cause mortality, where you expect to have a smaller fraction of patients dying from sudden cardiac death. You would expect to see a smaller effect size in this population. So again, that was the number from the trial was up around 0.7 to 0.877. What we're expecting here is a slightly sort of higher, which is toward the null effect estimate in this population. And in terms of the method, you see that mental buyer gave us the estimate closest to the null. So let's look at the PS matching because this is the one that I'm using in a second table. And then next one was landmark, and then the third one was exclusion method. So when we looked at the impact of time scale, now that we are sort of focusing on PS matching in terms of adjustment method and looking at the different method, which is in the column in this table, and different time scale, that you see that the time scale that did not have much effect on landmark or exclusion, but had some effect on mental buyer method. Another thing I actually had it as a backup, which I want to show you, is that, as I said, landmark, you have to pick a sort of arbitrarily cut-off time point. So we looked at different time points. The extreme time point would be the discharge is so that you only sort of classify patients who received ICD as a sort of treated at the time of discharge. That's the sort of extreme landmark. And then you could look at 60 days, 120 days. And as you see in this table, that the effect become closer to the null as you sort of use the time far away from the index hospitalization, which I think due to the fact that misclassification was happening when you pick up the closer date to the index hospitalization, and you sort of correct it as you sort of move away from the index hospitalization. But note that it's not, the direction is not toward the null, but away from the null, because it's only happening in one treatment group. So as I said, the biggest limitation here is we don't have a sort of absolute gold standard here. We're just guessing what that would be. And as I said, we anticipated a slightly sort of higher hazard ratio in this population because of the reason I mentioned. And another limitation is we have limited information on the timing of important events on the disease course. So there is no information on disease duration, and we know that the 3-year look-back period identified first hospitalization is not enough. Finally, it is really difficult to assess in this sort of real-world example the pure impact of the method handling time due to the unmeasured confounding and other bias come into play when comparing different methods. Again, that the population that we're using in different methods are changing, therefore that the other bias could come into play in terms of looking at different effect estimates. So in conclusion, mental buyer method resulted in most conservative effectiveness estimate, followed by the landmark method. The exclusion method produced hazard ratio farther away from the null, suggesting that Immortal bias was not handled properly, probably. The effectiveness of ICD were overestimated. The impact of time scale was minimum except in mental buyer method, suggesting that the method sensitivity to the choice of time scale. However, we really had limited information in terms of assessing the relative appropriateness of different time scales. So right now we've been really conducting, because of the limitation in the real-world data analysis, we've been conducting simulation studies to sort of look at this issue more closely. Thank you.
All right, we have time for 1 or 2 questions.
Hi, Jessica Chuback, Group Health Research Institute. I have a question about your diagram for the mental buyer method where you're talking about that first period of time as immortal. If it's classified as unexposed, I'm not totally clear on how it's immortal because they could have had a code during that period. I understand if they had, yes, so if they, at the time they had the green line, if you went back and categorized them as treated during that time period, then you'd be conditioning on survival up until that point and sort of backfilling. But if you treat them as unexposed and they had the opportunity to both have an event or become exposed during that period, I'm not completely following how that's
So this
immortal.
is actually categorized as an exposed. Maybe I was explaining it.
Okay,
in
so
mental bias. It's just a regular time-varying exposure assessment. That's what it is.
Okay, got it.
Yeah,
Thank you.
Sorry. Maybe the name was a little bit confusing.
Others? I guess that's all for now. All right, we'll get the slides set up for the next speaker, and this will be Jennifer Nelson, who will talk about exploring the use of validation sample methods to reduce confounding bias in healthcare database estimates of influenza vaccine effectiveness in seniors. Jennifer Nelson is from the Group Health Research Institute and the University of Washington, and the connection with vaccines as a diverse healthcare intervention. We're looking forward to that.
Thank you very much. Thanks to our symposium organizers and hosts for inviting me to be here today. It's a pleasure to share some of my work and to have the opportunity to discuss similar methodologic challenges with colleagues. So what I'd like to talk about today are methods that are applicable when we're looking at studying research questions in large healthcare databases. And in particular, when we're interested in supplementing or potentially supplementing the information that's available to us readily from the databases with potentially richer information. And particularly, this talk is going to focus on supplementing information about confounders. And so I'll present these ideas in the context of an influenza vaccine effectiveness example, which, as you'll see, arguably is maybe a poster child for challenges in looking at this question in healthcare databases. But I still think it's very useful to illustrate these ideas. So even though this example is not entirely cooperative, the ideas are generalizable to other products, potentially other research questions, both in the effectiveness realm as well as safety, which is where I spend a lot of my time these days. And so these are reasons why I like this topic. So here's a brief outline of what I'd like to talk about today. I'll first give a little bit of background on flu vaccine effectiveness estimates in seniors using large healthcare databases and talk about some of those limitations and a methodologic tool that we've used in the past several years to quantify the confounding bias that exists. Then I'll introduce a proposed approach for using validation samples, and in particular in this example, a two-phase sample, to try to remedy some of these limitations. And then I'll give some preliminary results and talk about where we're going with this work. So some of you may know there are many large database studies in the literature that adjust for standard large database confounders, so ICD-9 codes that look at chronic conditions, procedures, as well as utilization. And very consistently over many years, they show very large effects of flu vaccine in terms of preventing many outcomes. And here's all-cause death is one example. So here we show 50% of all-cause deaths in seniors can be prevented by flu vaccine according to these analyses. And these are consistent across many years, many sites, many populations of seniors, as well as different outcomes. So here's a more specific outcome of pneumonia and influenza hospitalization. So we see relative risks that are well below 1 and highly significant. What wasn't recognized and has now become more increasingly known is some inconsistencies that these studies previously didn't account for. And I'll start from the bottom and work my way up here. So the risk reductions that I just showed you are in conflict with biologic evidence that suggests that immune response to flu vaccine diminishes with age. So if you computed these relative risks by age strata, you would not see that happening. You would not see a weaker effect as age increases. The relative risk estimates are not specific to events that are reasonably attributable to influenza infection. So you could look at control outcomes or outcomes for which you would reasonably expect there to be considerably less of an effect, if any effect, such as injury or trauma hospitalizations. But we see similar magnitudes of problems, of effect sizes. The effects are not specific to seasons where there's a good match between the vaccine and the circulating strains. The effects are implausibly high. So I think in the literature estimates vary, but at most, and probably not probably half of this, but at most 10% of all deaths during flu season are attributable to influenza. So even if the vaccine were 100% effective, it couldn't prevent 50% of all deaths. It's inconsistent with ecologic data. So over the past several decades, vaccination coverage in the elderly has gone from 15 to 20% up to close to 70%, but we don't see the incidence of influenza changing much. And last, and what's become most interesting to our group is it's not specific. The effects are not specific to season of the year. In fact, if you estimate the effect of influenza vaccine prior to the circulation of influenza, when there would be no effect of flu vaccine because there's no disease to prevent, we see the largest effects during that period of time. And so this particular fact was noted in a study by Lisa Jackson, a colleague of mine, many years ago now. So this is a plot that shows what I'm talking about. So here we see this was a study across 10 years' worth of data within group health seniors, and we basically tried to replicate previous studies. And so this center piece here shows that we can do that. We can show that the relative risk of death for vaccinated compared to unvaccinated is about what people had seen in the past, around 50%. And we also replicated post-influenza analyses that had been done as well, which showed a diminished effect, which seems sensible until you look before influenza circulates. And there you see the largest effect yet, which must be bias. There's no flu circulating. There's no disease to prevent. We can't possibly have this. And so this is a control period which then can be used as a gold standard, if you will, to see how well a method is doing. If there's this much bias as measured using pre-influenza season, there's clearly residual bias likely happening during influenza season. And so in a companion paper to the study that I just showed, we did a case control study that investigated and tried to get at what the likely source of this problem is, the nature of this confounding bias. And we found the difference, not surprisingly, there are differences between vaccinated and seniors who choose to get vaccinated or not. In particular, there's preferential use of vaccine by healthier seniors and selective underuse by frail seniors. And the reason the database studies get the wrong answer is they don't adjust for these differences. ICD-9 code methods misclassify chronic disease, such as dementia, and perhaps more importantly, don't measure some things that are particularly important, like disease severity, or don't measure it well enough, and functional status. And so this table is designed to highlight this. So this is a case control study that went into the medical charts of a sample of cases and controls to measure other confounders and validate confounders from the large database. So what this shows is among cases, so the first column is cases, and controls who appeared to be not diseased by database confounding variables. When you went into their charts, you could find that 32% of cases actually had a diagnosis for dementia. Over half of them needed assistance for ambulating, and 30% needed assistance for bathing. Similarly, there were people. This effect was seen for controls as well, but not to the same extent. So this is differential. In addition, you can also see the rates of vaccination differing considerably by cases and controls. So this is really indication of what's going on in this particular example. So our goal was to collect better data, collect better information on confounders to see if we can reduce the bias, incorporate these data using validation sampling methods, and then see how well we did by using this pre-flu control period to determine how much we were succeeding in terms of reducing the bias. And so ways in which we could consider collecting better confounding information would be by doing medical chart review, potentially bringing participants in prospectively for in-person physical examinations. So these are very expensive things to do, too expensive to do in these large database studies. I think the group health study that I showed was on the order of 44,000 seniors. And in fact, we didn't have any funding, so we couldn't do any of this on anybody. But what we did have is a convenience sample available to us. Some existing seniors at Group Health have been participating in a long-standing way in a large prospective study, and I'll talk more about that in a minute. And so we wanted to leverage this existing information to see if we could improve the answers we were getting, which we knew to be suspect, using all of the data. So that we approached this from two different ways. And I'll talk more about this in a bit, but two validation sampling methods, imputation and inverse weighting. And then, as I mentioned, we wanted to use this pre-flu period, this control period, to see how well we were doing. So we could look at the naively adjusted estimates that we would get if we did it the way prior studies did it. And then we could also estimate using these validation sample techniques and use that pre-flu period as sort of a barometer for how well we were doing, because the effect should be close to 1 during that point in time. So here's a little bit of information about the data that we had available to us. So we had information on what I'll call this full sample. This was all group health seniors over 65, enrolled for at least a year and not in a nursing home. And on them we captured death status and time of death, vaccine status, each year for 2 years. We actually had this information across 10 years, but the overlapping bits of time between the full sample and the subsample were these 2 influenza seasons. The subsample is the ACT study, the ACT Adult Changes in Thought study, and so here we have a prospective cohort of dementia-free seniors who have in-person visits with lots and lots of confounding information. I'll leave it at that. So the full sample has standard measures of confounders, which I'll denote as error-prone confounders, so ICD-9 coded conditions, information about utilization, prescriptions, lab values, things we can get readily. The ACT subsample has what I'll call gold standard confounding information, more information about demographics, self-reported physical activity, physical function, chronic conditions, as well as more objective measures of functioning like grip strength. So as I mentioned, we took 2 approaches, and I'm going to focus on the imputation approach today. Imputation, so I like to think of this as orienting towards the full sample. So we don't have everything we'd like to have on everyone, but if we have a sample where we have both, we can use that information to impute what we don't have on the full sample. So basically, this method involves modeling the relationship between what we have on everybody and the gold standard information, and we do this within the subsample. Then we use that model to predict the gold standard information for those who don't have it in the full sample. This is a way in which you can also think about implementing regression calibration. The other way to think about this is orienting towards the subsample. So ideally, we would like to do this analysis in the subsample where we have everything, all the measures we'd like on everyone. However, there's not nearly enough people. There's not enough precision in that. And so what we can do instead is do a weighted analysis in the subsample where the weights weight up using information that's available to everybody. So using this error-prone information and weight up to the full sample, thereby gaining precision. So our question of interest, our quantity of interest, is the relative risk of death for vaccinated versus unvaccinated, and we use survival analysis to estimate this, in particular a Cox proportional hazards model with a time-varying influenza vaccination status, so it's 0 until you get vaccinated and 1 thereafter. We're estimating different effects by season, so in addition we have an interaction between season and the effect of flu vaccine before, during, and after. And we have several different models. A naive model where we use the full sample and just adjust for the error-prone confounders, and these 2 validation sample methods that I mentioned. So we all recognize that we have many confounders, not just a single confounder X. And so to reduce the dimensionality here, we're doing this implementation using propensity scores. So instead of adjusting for the actual individual variables themselves, we wrap it into a propensity score. So in the subsample, we can estimate a gold standard propensity score, and in the large sample, we can estimate the error-prone propensity score, in each sample using the information that's available to us. I won't talk too much about the model building, but just wanted to mention here, we started with an a priori list and then used techniques that are becoming standard to build propensity score models. We have a naive survival model where we have the full sample where we adjust for the error-prone propensity score. And then we have our 2 validation sample methods. One, the imputation approach, where we use the full sample and instead of adjusting for the error-prone score, we adjust for the gold standard score when it's available and the imputed value of it when it's not available. And this is actually an approach that was described by Sturmer and denoted as propensity score calibration. In the weighted subsample approach, we adjust for the gold standard propensity score, and then we upweight the results to the full sample based on the information that we have on everybody that can connect, and use the connection between the propensity score, that's the gold standard score, and the error-prone score when we have that information. And the particular weighting that we use is an approach proposed by Breslow and Lumley. I think this was just meant to be a visual aid to sort of describe the imputation, and I think I can come back to it if people want to want a better understanding. But I'll move on to some preliminary results. So we have 2 study years, and we have about 44,000 people in the full cohort each year and about 1,000 people in the subsample each year. Vaccination rates were about 70%, both in the full and subsample, and death rates were about 3 to 4%. And so this plot illustrates the very unique way in which influenza vaccine is received within populations of seniors and others. So this shows the timing of influenza circulation, So based on data, we know that flu season in this particular year, 2000, was from December 17th to March 18th. And so this period of time here is pre-flu, during flu, and after flu. These lines show you, among those who got vaccinated, the proportion who got vaccinated at any given point in time. So you see basically all vaccinations occurred more or less, or 90% during the month of November. So this happens quite quickly and actually explains a lot of why selection of receipt of vaccine is so is high. This is just meant to show a little bit more information about the two populations. So this shows demographic information, age and gender. The take-home message here is that these two samples are not exactly the same. In fact, the ACCEPT subsample is slightly older. We do see age and gender being similar between vaccinated and unvaccinated individuals, however. So here's a picture that describes how well we can predict the gold standard propensity score using error-prone propensity score. So this shows on the x-axis the error-prone propensity score and the gold standard propensity score on the y-axis. So you can see in the subsample there is a linear trend evident between what we know on everybody and what we would like to predict on everybody, but there's really a lot of variability. For a given error-prone propensity score value, there's a lot of different gold standard values that it takes on in the subsample, so perhaps not as much information as we would like. And these are the main results. So I'll start in the middle here where we see, so these brownish red lines are fully unadjusted, adjusted for nothing, maybe age and gender in the full sample. The blue lines with the triangles are the naive full sample approach that I mentioned, so adjust for the error-prone propensity score. So you can see the adjustment does virtually nothing. I think in the first slide I showed you the adjustment actually made it worse. We tried to go beyond what was done in the past in terms of existing methods and go into home health care methods that are available, so using richer information within the large sample itself. And so we at least don't go in the wrong direction. But we don't do much. When we impute, I would argue here we're moving in the right direction. We'd like to see this value, all these values, actually be close to 1, and we're sadly still nowhere near, but we've moved in the right direction, which gives us some hope that these methods in a less stubborn example of confounding could be usable. So our preliminary conclusions, I think this is a good idea. How good of an idea is this? It depends on a number of things. It depends on how well you can measure the things that you don't have in that subsample. So how much of that bias, how much of the reasons for that bias can be measured in the subsample, and how much power you have. I mean, this flu sample was relatively small and death is quite rare, so there's a lack of information there. The comparability of the subsample and the full sample obviously matters because you're relying on saying that how the propensity score that's error-prone and gold standard relates in that subsample, we're mapping that and assuming that's the case in the full sample. So you want to assume you can make, that's a big generalization to be able to make. The quality of the calibration, so that scatter plot with all the dots that I showed you, the better that prediction model is, the better that you'll do. And then you need to also be wary of other assumptions that are underlining each of those steps. For the flu example, as I mentioned, we have bias that's really difficult to remove, I would say. And I think what we can't measure here are the fact that these people who get flu vaccine are adherent people in general, and that's a difficult characteristic to measure. The comparability of our full sample and our subsample wasn't perfect, and nor was our calibration quality, and our power was somewhat low. We did explore some more complex models. There's sort of a suggestion that the propensity score acts differently by season, which is something we hadn't considered before. And actually, when you incorporate propensity score interacting with season, we see some more promising, but still not promising enough results. So those are the limitations in this setting. In other settings, the limitation is the lack of a gold standard control period. Influenza vaccine is very unique in that way, and we have this control period that we can use and benefit from. So our next steps, and we're in the process of this, are implementing this weighted approach, and this follows the same basic, we're fitting a similar model. We're just fitting it in the subsample and upweighting it to the full sample using weights that are essentially inverse probability weights tuned to be more efficient. I want to acknowledge collaborators who worked with me on this, who aren't here today, a biostatistician and several co-investigators, including PIs of the Vaccine Safety Data Link study, which supported this effort, as well as the ACT study, Eric Larson, as well as Thomas Lumley, a statistician who is on the other side of the world. And I guess I would just close by saying that despite the limitations in this particular example, I'm quite hopeful about the use of methods like this in other settings, for other products where bias may not be as difficult, and for cases that are not convenient samples. We can think carefully about planning to design two-phase sampling methods, measure the things we want to measure in the amount that will be useful and informative. And we shouldn't just restrict our consideration to thinking about measuring confounders better. We can also do outcome validation. There's misclassification in everything we measure in these databases, and it would serve us well, I think, to look into using two-phase sampling methods as ways to correct for outcome misclassification in addition. Thank you.
All right. Thank you very much. We have time for a couple of questions.
Thank you very much. This is a great presentation. When you see expected biases of this magnitude, I'm always thinking this cannot be confounding alone. There must be other major things going on in your pre-season effect. And I was wondering with regard to the possibility of differential exposure measurement error, that when elderly, frail patients get hospitalized, automatically get the vaccination when they're hospitalized. And to what extent is that recorded? Do you have complete recording? When you go into the community, the CVS, you get your flu shot, is there any record forwarded to your database?
We do have that information. We would get it if they submit a claim, and it trickles back to group health. I think the reliability of the exposure data is quite high. In this population, group health seniors tend to go to group health clinics and get vaccinated. If they're hospitalized, and maybe Bruce, you can comment on this as well, my suspicion would be that is not a huge source of the problem, but I could be wrong.
It's related because the direction is actually the other direction. The very frail people who are on their deathbed are not getting vaccinated. And then they go on to die, and that's why in the period before, as Jennifer was pointing out, it makes the vaccine look so effective because they don't die. So you have this curvilinear relationship, like what she explained, where the healthier people where the sicker people are more likely to get vaccinated up to the point where they get close to their deathbed, and then they become much less likely to get vaccinated.
It would be ideal to be able to know who these people are who cannot be helped by vaccine and exclude them from the population, because these are the folks who are contributing to this pre-flu bias, and they should never be included in this study. All
right, Jennifer, I have I appreciate how challenging removing the confounding was between the exposure to the vaccine and the outcome, but I had another encounter with flu vaccine, and it was when I was doing empirical identification of exposure, doing a propensity score, empirically identifying covariates, and one of them was past flu vaccine use. And given your findings of how tightly it's bound with some of these things like adherence and healthy user effects, does it seem reasonable to include that then in the propensity score for drug exposure?
I think you could, and many people have looked at prior history of vaccination, and is that predictive? And sure enough, people who get vaccinated year after year after year and then don't get vaccinated in that year have a high likelihood of dying. But it's fairly easy to explain that as a reverse problem as well. So yeah, that certainly probably deserves more attention to be looked at more carefully.
All right, thank you.
Thanks.
All right, our next presenter is Dr. Nahua Duan, and he's a biostatistician at Columbia University in the psychiatry department. And he's told me that in 2 weeks he's going to be retiring.
Enjoying, maybe I was hoping to be involved in some research as a hobby. Thanks very much to the organization committee for organizing this very stimulating symposium. Also, thanks to you for staying to this late afternoon session. So this work I'm presenting is a joint work with Richard Kravitz at UC Davis And part of the work was supported with funding from Pfizer. And the nature of the presentation is this is work in progress, and I will be talking about the conceptual development and a couple of pilot studies that we have completed and some outlooks for the future of this research agenda. Okay, brief outline. So well known there's a large gap between research and practice, and we believe there's a need for engagement of frontline practitioners to take a more active role into learning communities. And we illustrate with two examples, N1 trials for learning from within patient experience, and also what we call evidence farming for learning across patients within specific sites to help inform clinical decision making. And if time allows, I will talk briefly about empirical-based methods to combine knowledge across patients and across sites. Okay, so the gap between research and practice. Routine practice is often hazardous, and the process by which the learning from experience occurs is very often follows ad hoc try and error. And the research knowledge is usually produced centrally, and the relevance of the research knowledge might not be compelling to the practitioners on the front line, and therefore the uptake of this knowledge has been suboptimal. So with the disconnect between the research and practice, there has been a missed opportunity to learn more systematically from the local practice experience. So this prompts us to think that maybe we should take another look at how the clinical knowledge enterprise is organized. Okay, so the prevailing organization is a top-down model where the generalizable knowledge is produced centrally and then disseminated to the front line for adoption, implementation. And the role of the front-line providers is a relatively passive one. And there might not be a totally desirable organization. So we believe there's a potential that a more effective approach might be a two-way organization in which information from the local practical experience is also harvested into useful knowledge that could be used to help inform clinical decision making. So as an analogy, we thought that this model might be like the auto-titration CPAP device that is often used to treat obstructive sleep apnea. The device pumps a small air pressure into the airway to avoid or mitigate sleep apnea. And some of the devices deliver a fixed pressure, and some of the devices have this learning mechanism. So the host on the right-hand side, let me see if I can get the mouse out, has an interesting inner tube that is a sensor tube to monitor the condition of the patient and then feedback to the central device and to adjust the pressure. So the way the device operates is it starts at a relatively low pressure, and then as the sensor begins to detect sleep apnea or hypopnea, it increases the pressure slowly up to the point where the apnea is under control, and then it might gradually reduce the pressure. So the delivery of the treatment is adjusted automatically based on the information collected locally. So with thinking about that as a model, I believe that might be something useful to think about for the broader the healthcare the delivery system. So it is conceivable that maybe some frontline providers might not want to be limited to a passive role of studying the guidelines and studying the information disseminated to them. But it is conceivable that there might be an interest in taking a more active role and to produce local knowledge from the clinical experience within the specific practice, and then use that to supplement the generalizable knowledge obtained from the top-down channel to help us maybe calibrate or adapt the treatment delivery. So such a model, we believe, has the potential to engage the frontline practitioner into learning communities, and it might also motivate the more active data acquisition, because if the data is being collected for the purpose of delivering to the Columbia University and is never seen again, there's not a really compelling incentive for the practitioners to make a good effort to collect outcomes data, and that is very often the challenge that we see in comparative academic research. But if the data is collected, could be used for a local purpose for the practitioner's own use, then potentially there will be a stronger incentive to provide that data. And then the empirical-based methods can also be used to provide the synthesis between the local data and the aggregate data to provide this two-way interface. So in a sense, what we're proposing here is a system-level CER where the two different organizations potentially could be compared and evaluated to understand whether a two-way process might lead to better outcomes. Okay, so I guess the model we're proposing here is similar to what has been known in recent years in the literature as the medical-based evidence, or sometimes called practice-based evidence. And here are some of the recent key publications. And to note that Susan Hong and Julia Gaswin gave a presentation at this symposium several years ago on their work on practice-based evidence that was published in Medical Care in 2007. So our work builds on the previous work, but I think what is distinguished our work from the previous work, I think there's probably two dimensions. One important dimension is that most of the previous work on MBE or PBE is primarily focused on using observational data. And our proposition is that MBE or PBE or locally produced knowledge does not have to rely entirely on observational data. And we should not overlook the opportunities that a local innovation or experimentation potentially could be informative. And we'll talk about a couple ideas that we believe are pragmatic options that potentially could be promulgated in local practices. And I think another dimension where we believe our work expands upon previous work is that the previous work in this area mostly was focused on using the practice data to produce generalizable knowledge for, I guess, universal application. And our focus is to emphasize on to recognize the possibility of the heterogeneity of treatment effect that Serene commented on yesterday as one of the 11 high-priority topics for PCORI. And if the treatment effect can be heterogeneous, that means the same treatment might not work the same way across different patients, then there is a value to try to look at local information, to look at specific patient, how the patient responds to the treatment, or to look at a specific practice, to look to see how the patients in the specific practice responds to the treatment. So we'll talk about the first example that we're proposing to apply this methodology. So to learn from within patients, a promising paradigm is to conduct N-of-1 trials. So those are multiple crossover trials within a single patient. And I guess the procedure is to assign time intervals to the treatment, say treatment A, treatment B options, and then maybe switch over multiple times, and then compare the outcomes for the alternative treatments to see which treatment option produces better outcome for that specific patient. And the treatment assignment, so it's not across patients, but it's within patient and assigned at the unit of time intervals, say weeks. So the assignment can be randomized and can be blinded when appropriate, but it does not have to be. And so the focus here is on producing the local knowledge specific to the patient to try to resolve whether treatment A or treatment B is better for the specific patient, and so as to inform the decision for that patient. So the indications where this procedure might be appropriate include should be ongoing treatment for chronic conditions such as pain management, and especially in situations where many older patients might have multiple chronic conditions, and it is really a very difficult area to study because there are so many possible combinations, and it's very difficult to do the parallel group trials. And I think even with a large database, the combination of patients with multiple conditions might be so large, and this might be one possible way to inform specific patients about the treatment options that might be useful. And another requirement is that the treatment has negligible carryover effect. So this is not for surgery. Once you cut off the part, there's no more switch over that can be made. And this is useful when there is uncertainty about the therapeutic effects, and especially when the effect is potentially heterogeneous. So back to the point I talked about earlier. So I think on the broader framework, we're proposing a system-level CER to compare the use of this learning model versus a one-way dissemination model to inform clinical decision at a system level. But then at a micro level, within a single patient, this is a micro level CER for each individual patient to try to inform the decision-making for that individual patient. And I think as we discussed yesterday, I think this is also an important part of the goals for PICO. Okay. So we published a literature review last year on the N1 trials that have been published in the medical literature since '85 when the field about started. And we identified about 100 articles that includes 108 protocols and a little over 2,000 patients. So most of those trials are randomized and blinded. And the decision rule and stopping rule for those trials are varied. And more than half of the trial, to our surprise, came to a conclusion without any statistical analysis. It was reported. The decision was based on visual or graphical comparison. And then there are about half of the studies that reported t-tests and with various methodologies. Some use 5% significance, 10%, 20%, and this is an area that we definitely believe, we believe this is a promising paradigm. At the same time, further methodological development is definitely warranted. And I think Dr. Schmidt, who presented early this morning, is one of the biostatisticians who has been leading a good methodology development, like empirical-based methods in this area. Despite those limitations in the current methodology, the findings of those trials, right or wrong, were influential in the subsequent treatment decision. So among the patients for whom the trial finding favored the initial treatment, 95% of them stayed with that treatment. And among the patients whose trial finding favored alternative treatment, 84% of them followed that finding. So those are influential trials, but I guess the methodology needs more work to be further developed. We did a pilot study on the acceptability of this methodology that was published a couple years ago. We interviewed 21 physicians and 32 patients. So some of the findings were encouraging. The clinician one of the clinicians made a very nice point that it puts a little structure into the idea, why don't we try this medicine and see how it goes? So this usual practice is try and error, and this is to make the trial and error more systematic and try to do it more rigorously. And some patients made very keen observations, like us. It will show which one's better for you personally, rather which one's better for this group. And then you take the two different things yourself, and you don't have to compare yourself to somebody else. The patient recognizes she is being used as her own control. That increases the credibility of the finding to her. And so there's also recognition among the physicians in our survey that this is potentially an important game changer that cuts both ways. On the one side, they recognize this can help enhance communication with the patient and maybe encourage better physician-patient relationship. On the other hand, some of physicians were also very concerned that their prestigious authority over the patient will be compromised because they will have to tell patient, I don't really know which treatment is better for you. Let's try it out. Okay, so we believe this is a useful methodology to inform a personalized treatment decision for individual patients, to improve therapeutic precision, and having the same patient serve as home error control, and systematic application of the common practice. So what we're advocating here is that this is not to try to import a foreign and a very difficult RCT into practice. But this is something that is the good practitioners are already doing, but in a not systematic way. But this might be a way to try to elevate that usual practice into something that's more informative. So as our pilot study showed, we believe this is potentially acceptable to a number of practitioners. And this will potentially benefit from developments in information technology, and our research group is in the process of applying for a grant to develop the infrastructure support for the N1 trial system through a mobile health application. And there's a subtle question whether this should be considered as a quality improvement clinical practice or human subjects research under the IRB purview. And some of our collaborators, like Dr. Sunita Vola at University of Alberta, were able to convince their IRB this is real practice, clinical practice, quality improvement, so they would receive expedited review. And further method development, we hope that we will be able to work on in the future. Thanks much. So I think I will skip the other section.
All right. Thank you, So we'd like to move on to the final presentation for today, and this is Jason Connor, who will talk about Bayesian adaptive trial design in comparative effectiveness research, and furthering the theme of diverse healthcare interventions. The intervention in this case is interventions for status epilepticus.
Right. Thank you for the introduction and for the organizers for inviting me here. I know it's been a long day. My topic is probably maybe the easiest to follow, so someone was good to put me last for that reason. So living in the clinical trial world, I think I get to answer interesting problems, but they're probably not as challenging as many of the really, really hard ones that we've heard about using observational data that come with all sorts of complexity. So I have some benefits, but I'm going to talk about a Bayesian adaptive trial in status epilepticus, which is basically having seizures and some different types of seizures. So my conflicts, I'm going to talk about 3 drugs here. All 3 are generically available. I frankly don't even know who makes them. I'm not working for the drug companies here. I do work for a bunch of drug and device companies, but not any that I'll be talking to you about. So this is part of, I work with a group that got a grant called ADAPT-IT, which is the Neurologic Emergency Treatment Trials Network, a group of emergency physicians doing neurological outcome trials like stroke and such. We got this grant to redesign essentially these emergency room trials using Bayesian adaptive methods, and the one particular one I'm going to talk about is ESET, which is this status epilepticus treatment trial that we're putting together with a bunch of neurologists. So a whole bunch of collaborators contributed to this work. In particular, Jadip Kapoor is the PI of ESET. Jordan Elm is the head statistician at the group that will be collecting the data, everything. And Christine Brolio is one of my colleagues at Berry Consultants with whom I'm doing this. So our research question is basically patients come in, they have a seizure, they come into the hospital. Pretty much everyone gets benzodiazepines first, but in some patients benzodiazepines don't work. And then what? Well, currently patients get one of these 3 drugs. So fosphenytonin is actually approved for this. The other 2 drugs aren't approved for this, but it's not even clear which of these 3 drugs works best. So all of these are commercially available for other things. They're being used off-label here. So this would be an NIH-sponsored trial to figure out which of these works best. So it's a true comparative effectiveness study in that way. Which of these things should we be doing? And, there are differences that I won't get into a whole lot about pediatric versus adult populations and even senior populations. So the endpoint here is a composite endpoint. Can we make your seizure go away rapidly within 20 minutes? Can we make it so that you don't seize again, so we don't need to give you more medicine in the next 2 hours? And is there no significant adverse event? So we're including efficacy and safety in a pretty simple dichotomous outcome. And the good thing about this outcome, one of the things about Bayesian adaptive trials is they work best if there's a rapid time to endpoint versus accrual rate. If I have a 12-month outcome but can enroll everyone in 3 months, I can't help you much as a Bayesian adaptive trial designer. So we have a fast endpoint here. So this is a prime place for an adaptive trial. And this is comparative effectiveness. So most of what I do is actually for FDA. Drug companies or device companies come to me to help them, get something FDA approved. And so, there's differences in those sorts of trials. One key one is type 1 error means a lot different in comparative effectiveness. If I have a new cancer drug and I make a type 1 error, that means we approve something that, in fact, doesn't work. So we're giving someone a drug that has, adverse event profiles and costs money and isn't doing them any good. In comparative effectiveness, type 1 errors probably aren't as bad, right? I mean, if I'm a manager of a baseball team and I have 2 people who are equally good hitters, it doesn't matter if I erroneously declare one is better than the other. If they're equally good, it doesn't matter, which one of those 2 I pick. That said, we're still going to think hard about type 1 error control it, but, it's worth thinking a little differently in comparative effectiveness. And what do I really want to know? Well, I really want to know what drug is best and how certain am I that that's true. One of the things we'll talk about is stopping trials for futility. I hope the alarm does not imply that my talk should stop for futility here. If someone back there smells smoke, let me know. We'll all leave. So, comparative effectiveness trials, right? We've all done our own comparative effectiveness trials. So I live in Orlando. There's a relatively new medical school in Orlando. It's down here by the airport. There's not a whole lot of cool places to live in Orlando. So let's say you move to Orlando and you live up here in one of the cool places. So the question is, how do you get to work, right? So you can go down and over on the highway. You can go over and down on the highway, or you can kind of take surface roads and get to work. So, you've all moved to a new city, started a new job, and you've had to figure out, how do I get to work? So, what you do is, if you're not a statistician, many of you are, if you're not a statistician, you seek out a statistician, and you say, help me figure out how to get to work. And he asks questions like, well, what's a clinically significant difference? And you say 5 minutes. Like, if it's 4 minutes, I'm going to go the prettiest way. If it's 6 minutes, I'm going to go, the fastest way. And he says, okay, what's the standard deviation? And you said, I knew you were going to ask that. I have pilot data, 7 minutes. And then he does some calculations, and he said, if you go each way 40 times, you'll have a 90% chance of identifying the best one. So here are these envelopes. Every morning when you have your coffee, rip open an envelope, go that way, email me how long, and in 120 days from now, about 6 months, I'll tell you how to get to work from now on. So I know that's how all of you choose how to get to work.
Blinding? How does the blinding work out?
And it's hard to do here. Not blinded. The DSMB would not approve the blinded study. Right. So we understand that certainly trials and randomization, all that's good. I firmly believe that. But the idea of fixed trials, it's worth to me thinking about, well, what's a better way to do this? So how of course, do we do this? Well, you try one way, you try a different way, and you get a sense for what's better, and you stop going the bad ways, right? And there might be, a day where it's not too busy a day, you don't have early meetings, and so you go the way that you've kind of not been going for a while. And either you go, oh, this way's faster than I thought, I'm going to try it again someday soon. Or you go, oh, now I know why I never go this way. And so you never go that way again. So it's the same thing here, but why do we do trials? Because we understand error rates. We understand type 1 error. We understand power. I'm a Bayesian, but I'm a firm believer in understanding type 1 error. So that is important. But we can combine these two things, right? We can do something adaptive, pick the best way to go, learn as we go, try to figure out the answer faster, but at the same time, as long as we pre-specify everything, we can come up with those error rates that we want to know. And generally, that's kind of why we do fixed trials, because it's easy to calculate error rates, but we can do something adaptive now and still calculate error rates. So the trial I'm going to talk about here, that we want to adaptively allocate to favor better treatments. That's going to help patients, but it's also going to help us as statisticians. If at the end of the trial you put a patient on essentially the worst arm, that patient isn't telling you any information about identifying, what's the best arm, because it's still one of the two other arms left. We want to drop arms that are performing poorly. Again, that'll help patients, and it also then we can reapply those patients to arms that we still care about. And we're going to stop early if we know the answer. So how does adaptive allocation work? So here, we're just, I didn't say at the beginning, so we basically, like all trials, right, the maximum sample size is kind of determined by resources. It's not really determined by what the statistician says. So there's about, you'd laugh, that's true, right? We all know that's true. Anyway, so there's about 795 patients in this study, and that was a bit of negotiation between what was feasible and what statisticians said. So a total of 795 patients, but after 300, we'll kick in adaptive randomization here, and then after every additional 100 patients. And part of this, because this is an emergency room setting, there isn't, there's just going to be a bag on top. So there's going to be 3 stacks of bags, where each bag is a drug, and there's going to be like the pediatric, the middle-aged, and old people. And when someone comes in, you grab the bag on top. So there's no sort of IVRS or anything like that. So we didn't want to update randomization probabilities too often, because updating randomization probabilities actually meant someone had to go in and reshuffle bags, and there's place for human error in this. We wanted to minimize that. So we're only updating randomization probabilities every 100 patients, starting when 300 patients are randomized. So we're going to favor treatments that do better, favor treatments with greater uncertainty, and basically what that means is, so we have let's say, 2 treatments, one's doing better than the other, so we randomize more to the better one. And then it does not as good, and the next time the other one catches up. So now they're doing equally as good again, but I have a higher N on one than the other. So in the next round, I'll favor the one with the fewer patients to kind of try to let it catch up. So we're favoring better treatments and treatments with greater uncertainty in the parameter estimate. And updating every 100 patients is about every 6 months. If the probability of allocation ever is less than 5%, I'm just going to round that to 0 and reallocate between my 2 arms. And if the probability of success is ever bigger, if the probability of success rate is bigger than 25%, is ever less than 5%, I'm just going to drop that arm for good and never go back to it. So that's my adaptive allocation, and there's, of course, equations here that nobody wants to see at 3 o'clock in the afternoon. So early stopping at 400 patients, we start the possibility of early stopping. And again, every 100 patients, we re-examine that. So if ever one particular arm has a 97.5% chance that it's the best arm, meaning that it's the probability of being the highest success rate is higher than the other two arms, we stop and declare it the winner. And for futility, rather than looking at something like just a plain p-bat value, what we calculate is we take our current data and calculate the predictive probability of successes. If I keep going all the way out to 795 patients, which is my maximum, what's the probability I identify a best or a worst drug? And if that probability is ever less than 5%, I stop my trial for futility. And we also talked about arm dropping. If we drop all three arms, of course, the trial stops for futility here too. So one interesting thing, remember I said we start adaptive randomization at 300, but we start early stopping at 400. One reason we do that is to lower type 1 error. So what happens if we would have started them both at the same time is that if one arm, even let's say all three drugs are completely equally effective, if we just see a random high and we allowed early stopping and adaptive randomization to start all at once, we might make a type 1 error and declare this drug's better. Here, if one drug is doing way better than the others at the first analysis, we won't stop early yet. We'll instead adaptively randomize, and almost all patients will go on to that drug. And if, in fact, it was a random high, probably what will happen is we get regression to the mean in that next 100 patients. So if you start early stopping after you start adaptive randomization, you tend to get lower type 1 error rates. So that's one reason for that. So I'm going to show you what the data would look like at the end first. So this is a trial that we're pretty much done designing right now and we'll submit. So this is example data. So here are the three drugs, and we show success rates like this has 65 out of 126 observed, and VPA has 194 out of 298. And notice the success rates here, it's 69%, here it's 58, here it's 52. These are posterior probabilities, and it's narrower for VPA because the best drug had the most patients randomized to it. We essentially didn't randomize nearly as many patients to this, which is good for patients. But, we're still pretty certain that this drug is better than this drug. So most patients went on this, and our precision of the drug we care most about is also smaller. And because we're doing this in a Bayesian world, we can calculate things like the probability each is the best drug and the worst drug and all sorts of pairwise comparisons. So just to demonstrate how this would work. So at a first analysis of 300 patients, we've equally randomized. And of course, in a real trial, these wouldn't be exactly 100 probably. But we can see that valproic acid was doing the best here. The probability each of these three is the best is 3, 9, and 88%. And there's an equation behind how we update our randomization probabilities. Some trials just use the probability each is best. We attenuate that in a way, but we still randomize instead of 1/3. We essentially randomize 2/3 of all patients to BPA for the next 100 patients. So we do that, and in fact, we see in the next 100 patients it wasn't the best. Just out of the next 100, that LVT was the best. Still, overall, it's not as good, but the treatment effect isn't as dramatic. Here it was 9%. Now it's just 5%. And we randomize patients, still favoring VPA quite a bit. And we're randomizing very few patients now to fosphenytoin, a few. And we calculate now our predictive probability of success if we keep going to the end. So there's a 50% chance that by the end of the trial, we identify one drug as either the best or the worst. We randomize the next 100 patients according to these randomization probabilities. And when we do, we in fact see the drug that looked the best is still doing the best in our new wave. And so this got bigger again. So now we're randomizing 70% of new patients to valproic acid. And remember, if this number has to be 97.5 to stop. So we almost hit a stopping point. If that number had been 97.5, we would have stopped and declared valproic acid the best. And in our next wave, we see, in fact, 80% of the next 70 approximately patients that got randomized to it were treatment successes, and it's now pretty evident that there's a 99.2% chance that valproic acid is the best of these three treatments. So the trial would stop early for success here, and we could go and publish. And so the idea here in this example, is that we're learning as we go. We're updating randomization probabilities, and we're treating patients better, but also learning rapidly. And then this would be the final analysis that I already showed you. So that's one example, but the key is, well, how does this work on average? Or, how do we actually expect this to work? So we can simulate this in numerous scenarios. So we have, our null case where each of these drugs works half the time, a good case where one is 15% better than the other, one where one drug is just 15% worse than the other two, one where there's, sort of a linear effect here, and one where there's all really bad. So in the null case here, on average, we have 545 patients. Remember, it could go up to 795. So these tend to stop early because the trial's realizing, even if I expend all my resources, it's improbable that I identify either a drug that's better or worse than the other two. The probability that I identify one is the best is just 0.02. So this is our type 1 error rate here. So that's low, that's good. And the probability you get randomized to the best treatment is 100%. All three of these drugs are equally effective, so everyone gets the best drug. When one is good, so when one is 15% better than the other, our mean number of patients is pretty low. We tend to stop at just the second possible interim analysis here at 500 patients. The probability we identify the best drug in this case is 94%. That's our power, so our power is really high. In fact, 89% of the time we do that early. 5% of the time it happens at the 795 patient analysis. And here the probability you're randomized to the best patient is 48%. So in a typical fixed trial, all patients would have a 1/3 chance of getting the best drug. And here there's in fact a 48% chance. So more patients are getting better treatment. And in fact, this of course means that for the first 300 patients, everyone's getting a third. So if you're in the latter group of patients, there's a very, very good chance you're getting the better treatment here. And we can see this for other ones. So these are operating characteristics we look at to ensure that, the trial is doing smart things. And of course, you can, change some of our, the way you choose to randomly or update randomization probabilities. There's some of the cutoff bounds for early stopping and resimulate. And we did that many times. And, much thought and trial and error sort of went into the bounds that we chose to operate the trial and these operating characteristics. So just to summarize here is that comparative effectiveness, which is the focus here, is really an ideal setting for Bayesian adaptive trials to learn as we go to ensure that patients within the trial are getting treated well and we're not giving, especially patients at the end of the trial, treatments that the DMC may know are probably treatments they shouldn't be getting, but no one else knows that. That it's okay then to do interim analyses early and often. I mean, we live in a world, right, where I can go on my phone and look at soccer scores from the Euro Cup right now, essentially real time. So, it should be possible that a patient that had a seizure, 3 hours ago in Seattle who got treated and who is doing well, that can hit, our database so that when a patient comes in, tomorrow in Miami, maybe they can reflect that. That's not an impossible thing given the IT infrastructure that is just, the world that we live in. That we can steer patients away from poorer therapies and stop trials as soon as we know which one is better. And that, to me anyway, this is just really a more natural way that we all make decisions, and so it's a natural way to design clinical trials. That's it. Thanks.
All right. Well, thank you very much. We'd like to invite all of the discussants in today's last session to come up and then you have open for general questions.
This is Sebastian Stiebers. Maybe I start seeing Jennifer and Jason sitting next to each other. I see lots of parallels here between adaptive trial designers and drug safety monitoring strategies, right? Like a mini sentinel. Can you make the link here? Make it more explicit?
Yeah, I was thinking the same thing, and I think what's important to do in the drug safety setting is to think about what are the important operating characteristics. So the ones that Jason showed were very relevant to the decisions that need to be made in that setting, and recognizing the trade-offs between the cost of the false positive, the cost of the false negative, which are different in a safety setting. And so I think what I heard, which is useful for places like Mini Sentinel to be thinking about, is careful thought in terms of operating characteristics, careful planning in advance about when do we want to signal, and how then do we define the thresholds on which we'll signal, how often should we look, and that there hasn't been that much or enough discussion about these issues. And I think thinking about it in a systematic framework like you presented is really important.
Yeah, it's a good question. It's a hard question, and one of the outcomes here is significant adverse event. But of course, as the designer, you have to decide, what is significant. And there might be something that, like with fen-phen, no one saw heart valve damage coming, and it wouldn't have been included in an adaptive design, of course. So a DMC always has a role there. But at the same time, including those to the extent you can is good. We had a lot of discussion. There's the NET that I mentioned, which is a Neurologic Emergency Treatment Trials Network, is doing this. There's a group called PCARN, which is a similar thing in kids. So we're using both of these existing networks, and the PCARN people had a big concern that essentially the drug that worked best in adults wouldn't be the best in kids, and so we're adaptively randomizing, and over half of these people are adults. So are we adaptively randomizing to children what might not really be the best in children? And so we thought about splitting them and making all these rules, and we ended up just that the DMC basically can look, and the DMC can flip a switch that makes it flat randomization for children and shuts it off. We have no reason to expect that it will be different in kids, including the safety profile. But that's one of the things we had to think about and include. But right, so including multiple outcomes is really great, and including utility functions. But it's still tricky that with safety, we're never exactly, sometimes we're sure. Someone mentioned claudication. I was on a claudication DMC where we did something adaptive because you know what to expect in claudication in some ways. But in a lot of things, you don't even know what to expect with safety profiles. So it does make things pretty hard.
I think the other point, too, in randomized versus not randomized settings is the emphasis that one should put on things like type 1 error versus bias due to confounding. I mean, we all do sensitivity analyses that try to capture how wrong we could go if we make different assumptions about things and misclassification of our data or confounding. And so I think taking into account the statistical variation is important, but I think it would be good to have more emphasis on looking at different sources of bias as well in terms of thinking about where to set those stopping boundaries.
This is Bruce Fireman. One issue that might come up in both the safety and that I was thinking about in your context is when do you stop? And I guess for futility in your context, I suppose you were saying there's very little value in reducing the uncertainty and that there's no difference among these three. If you start out, with a lot of uncertainty, if you kept going, you would be able to conclude with more confidence that they were all pretty much the same, but you decide that's not worth doing, and that's futility, probably based on your sponsor's concerns or whatever. But there's a similar thing in safety where we're always wondering about signaling and all that, but there's also some value in narrowing, if it's safe, and getting more and more a narrower and narrower confidence interval around your null hypothesis. So I'm just wondering how you what was the rationale for calling it futile when you knew that by the end you weren't going to be able to rule in favor of one?
Right. Yeah, so that's a really good question. So there's I heard two in there. One is, I've heard a lot of people say we should stop trials early for futility, but we shouldn't stop trials early for success because we always want as much information as we can about safety. And that's, a tough question. If I'm someone prone to seizures, maybe I want to know this information as soon as possible so that my doc can treat me the best, right? So I think that's a tough one. It probably depends on the clinical setting. In terms of futility stopping rules, here, since this is, in the FDA setting, if Johnson & Johnson knows they're not going to be statistically significant, even at p equals 0.09, they may as well stop because they need a trial that is to get approved. It's not black and white. But here, it's totally different in comparative effectiveness. And one of the things we asked, we had our group of clinicians, and we said, okay, if at the end of the trial it's 80% versus 10% versus 10% that each of these three is the probability of being the best, that's not a statistically significant p-value. And when we translate it to frequentist, would that change your practice pattern? And the answers were all over the board. And some said no, because it's not statistically significant. And some said, oh, absolutely, because you still need to pick one of the three when one of the patients come in.
Pick one of the three,
right.
And even if you're never going to meet your initial criteria for calling one a winner,
right.
If you got to pick one, why not pick the one that's out in front, and you'll have a better notion of the lead.
Right, and the difference was, we simulated that and looked at individual trials, and basically, you're taking one that is, if it's sitting at a 60% chance of being the best versus, say, 20 and 20 for the other two, even if we went to the end, that was just going to be 70. And so they're still going to pick the best one. So we basically thought pretty hard about that question and realized the utility of crossing this magical bound that we all believe more than we should in, apologies to the frequentists in the room, was really strong. And the utility of going from 60 to 70% in a posterior wasn't as strong, and it was worth, saving NIH's resources and getting the information out of there. But, I don't think that's, it's for sure the best way to do it, but it's something we thought really hard about within the group.
Bob, Glenn, I have a question for Jason as well. In the setting of adaptive allocation ratios, are there particular concerns about the possibility that the absolute rates might be changing in the later recruited patients? As you bring on new centers in a multi-center setting, we get concerned sometimes about the individuals from a certain location having a different absolute event rate. And do you monitor that, and what do you think about it?
Right, so that's a good question. That's a question I get a lot. I think if new centers are coming on, there's possibility for that. Here, fortunately, we were operating, there was just a trial published in the New England Journal 2 months ago in status epilepticus that came out of this network. So the fact that we have existing sites within our network, basically all sites turn on at the same time, which is a benefit there. And so that's something that we've thought a lot about and basically believe that the benefit of adaptive randomization far outweighs sort of that possibility. Like, we recognize it's a possibility, and we frequently invite people who ask that question that if you have a trial where there's this big shift in the underlying success rate, show us. Like, we would love to actually have data there, but there aren't really many examples of that. I mean, if I'm doing a breast cancer trial and I'm shifting to the treatment that looks better, suddenly Herceptin is approved, and now no one that's HER2 positive gets in my trial. So I have an easier-to-treat population getting my experimental drug. That's a huge bias. But how often do the game changers like Herceptin get approved in your indication during your trial? That's pretty rare.
Particularly monitor for it.
Right. So during the trial, like in DMC reports, we may put the underlying rate, but we also know as statisticians that there's huge variability, and even if you chunk things in 3-month windows, there's huge variability, even if there's no true change at all. So it's hard to tell, basically, if there's really something going on. But we get that question a lot and think that it's still worth doing. By the end of the trial, there's no use statistically or for a patient randomizing a patient to a drug that's not working. But it's always something to track and keep in mind.
Hi, Carlos Blanco, Columbia University. So I wanted to ask you also, Jason, whether you can extend this methodology to treatment-resistant conditions, to people who do not respond to the first treatment and then may have to do sequential treatment. So, for instance, if you're treating schizophrenia, people may not respond to the first antipsychotic, and then you want to try a sequence. Can you extend this methodology to that type of trials?
Right. And so is the question there the idea of being adaptive within patient? So now a patient would come back, and in this case, fosphenytoin didn't work, so do we right. So I haven't done that. I don't know why you couldn't. It certainly gets more complicated, but I think that's true in any trial like that. But I think you certainly could, but I personally haven't, so I don't have a good example to share.
Quick question, Jason. I'm just wondering, I'm a health economist, I'm a biostatistician or an pharmacoepi person. Could you talk about the equipoise in this trial, and does everyone choose to be randomized, or can they choose to have a treatment prior to? Right. Are the physicians making choices, and the people for whom they think there's equipoise, then they get randomized? And could you, if that's the case, can you talk about the implications of that relative to CER and making inferences about the results at the end?
Right. So this, and basically all the trials we're doing in this setting is interesting because patients aren't giving informed consent. They're in the ER seizing, and so there's other issues that we put public service announcements on the radio, and it's sort of bizarre. Like, if you don't want to be in this trial, wear this bracelet so that if you do have a seizure, we know not to put you in the trial, which is sort of, like no one, of course, wears those bracelets. But for DMC stuff, you have to do it. So I think as a doctor sees these patients, and if for whatever reason he would think he's not appropriate for fosphenytoin, then he wouldn't put him in the trial. But I think that's sort of like most trials where if the individual doctor doesn't, / patient in most trials doesn't have equipoise, he wouldn't put him in the trial. He'd just do what he wanted. And all three of these are available, so a doctor could choose. Unlike many trials where you couldn't actually choose between the treatments, he could here because, they're all available. So I think it's the same situation as most trials here. That it's not different. The equipoise consideration isn't different the way you asked because it's adaptive.
First choice, does that first choice get modeled in somehow? Because that is affecting the inferences that you can make in the long run about who gets to be randomized and who doesn't.
Yeah, I guess, I mean, it's fair to say then that maybe at your site has a slightly different patient population than my site, because if I'm a doc who favors one drug, and I think, oh, I know it'll work in this patient, so I don't put him in the trial. But again, I think that's true of non-adaptive trials too. So the answer is no, we don't model that in. And maybe we should, but I don't think that that has particular implication in an adaptive trial.
So just a quick question for Nahua. So the N of 1 trials they're not really a new thing, but why are they not getting adopted more in the healthcare system? What are the impediments?
Thanks for that. That's a very good question. So the paper that we published several years ago, I forgot to mention that in our slide, there is a small bibliography of several papers, including Chris Schmidt's very nice empirical-based papers. So we did discuss the barriers on the methodology, and part of the important barrier is the infrastructure. So for individual practitioner who wants to do an N1 trial, it's not obvious how she would do it. And so that's part of the reason why we're working to develop the infrastructure through the mobile health. And another barrier that has been significant is the human subjects regulation. Although it can be argued that this is really quality improvement and clinical practice, because this activity, the primary purpose is not to produce generalizable knowledge. It is to produce local knowledge specific to the individual patient. The use of randomization and the use of the term trial invokes the knee-jerk reaction in the IRBs. So typically, most IRBs consider this to be research, and that's under full IRB review. And the only investigators group we know of is that was able to get an exception from the regulation is Sunita Vola's group at the University of Alberta. That's the issue I think that really has to be addressed. HHS is working on revamping the entire common rules, and I think the purpose is to try to avoid overburdening regulations on low-risk activities. And I'm hoping that if N1 trials could be classified as quality improvement instead of human subject research, it will make it much easier for practitioners to do it.
All right. Well, please join me in thanking all the speakers for this afternoon. All right. Now, Sebastian and Scott will have a closing.
So very briefly, thank you, everyone. This has really been a wonderful 2 days of presentations, and I hope you all have enjoyed it as much as I have. And I want to be kind to our speakers because actually their work is just beginning as we put together the journal supplement. Everyone will be invited to submit their papers for peer review in the journal supplement. We are in sort of final negotiations with a couple of journals. We haven't signed the contract yet. It'll either be a clinical epidemiology journal or a health services research journal, and we hope by the end of the month to have that tied up. Also wanted to tell you that we've secured funding to have at least one more conference symposium next year, so we are in the initial planning stages of what that'll be. We're working with the National Institutes of Health, specifically with NCATS, which is the newest center in NIH, National Center for Advancing Translational Sciences, the home of the CTSA program. So as you are thinking about this conference and looking towards the future, we would very much appreciate your input. Liz sent around an evaluation at noon, so in your mailboxes when you get home, if you haven't checked it already, there'll be a very brief survey, and we'd very much appreciate some feedback about how this conference went, and then also your ideas about next year's conference. We'll have probably a pretty big focus on rare diseases, which is a thematic area that we haven't covered in the past 6 years of the conference, but that also leaves a wide variety of topics yet to go with. So look at your emails, and we'd appreciate you to provide those feedback. Lastly, as I mentioned in the opening remarks, our new best practice guide or user guide for developing CER protocols will be published in a couple of months. So look to that, and I hope that is a resource for you as you think about designing new studies for CER. And with that, Sebastian, would you like to say anything?
Germany leads 2-0 against Holland.
So with that, we will close this session, and safe travels to everyone back to where you're headed. So thank you.